Welcome, everybody. Thank you for joining us. We'll just start in a minute. Get everybody a couple minutes to populate over from the waiting area. All right, welcome. Thank you for joining us today for this special session called Approach and Management to Newborns with Prenatal Opioid Exposure. My name is Chantel Lincoln, and I am with Drug Free America Foundation as the Deputy Director. We're happy to co-host this webinar today with the Global Women's Network, and I have Senga Carroll here joining us as a representative of the Global Women's Network. She is a senior clinical and policy advisor. And today we have special guest Dr. Alison Sweeney. Dr. Alison Sweeney is an associate professor of pediatrics in the Department of Pediatric Hospital Medicine at UNC Chapel Hill. She serves as a medical director for the UNC Main Hospital Newborn Nursery and the Newborn Nursery at Onslow Memorial Hospital. She has a special interest in the neonatal opioid withdrawal syndrome population within the newborn cohort that she cares for and has participated in multiple quality improvement projects, both local and statewide, to improve care and outcomes and to create a positive environment for these infants and their families during their birth hospitalization. So let's welcome Dr. Sweeney.
Thank you, Chantel. Now let's see if the technology is going to be as nice to me as you were just now. Even though we practiced, I feel like it doesn't always go the way you want. There we go. And can everyone see, can you see my slides?
Yes.
Yes.
Okay, awesome. Thank you so much for having me. I'm very excited to be here and to talk about this really important topic that I've had quite a lot of experience with. I will say that in my disclosures, I do not have any financial or research disclosures other to say that I'm not a researcher. I'm a clinician. I do a lot of quality improvement work, both with our statewide quality collaborative and then also in our nursery itself to improve lots of things. And our drug exposed population is one of them. We have a nice relationship with a department in our institution called Horizons, which really helps us make sure that we give our moms, babies, and families the best opportunities they have. And this is a topic that's near and dear to my heart. The other disclosure that I have is that I talk very fast. So if at some point I'm talking too fast, I need someone to say, hey, slow it down. Coming from New York, New Jersey, that's a common problem that I have down here in North Carolina. The other thing is that because I don't do lots of research, I will present a couple of research papers and topics in the talk, but I'm not going to go super in depth. For me, it's more about clinical care and how we take care of these patients based on the research that was amazingly done by some of the people that I work with and some of the people who write really great papers and teach me really great things. So some of the objectives that I have for this talk are going to be to review some of the signs and symptoms of babies, infants who have been prenatally exposed to opioids, and also some of the implications of what it means to be born in that clinical scenario and situation. And then we'll talk a little bit about some of the strategies that we use here and that are used more or commonly around the country and of the U.S. and then also the world for treating and evaluating these babies once they're born. The one I'll talk the most about is called Eat, Sleep, and Console, which is sort of a newer management plan, strategy, approach to these dyads. And then we'll talk a little bit about the team-based approach of how, from my clinical experience and from sharing with people at conferences, that we have found a great way to take care of our mother-infant dyads, hoping to decrease some of the bias, some of the confusion that a medical team can inadvertently give to or provide a patient, and so that we can sort of explore that. And then if there are questions about that or comments, I would love to learn from you as well. So one of the things that I think is important is that what I'm going to talk about, or what I'm going to say the whole time during this, mostly because I will slip probably, but is the word nows. And so what is nows? Nows is what we now refer to as the withdrawal syndrome that a baby has after they're born to a mother who has been using or has been exposed to drugs during pregnancy. And the common name for that prior to the last couple of years was neonatal abstinence syndrome. And so it is more accurate to say nows because the baby is withdrawing and not abstaining from what is causing their symptoms clinically. And so really what nows is a drug withdrawal syndrome that we see in a lot of babies who were exposed to especially opioids during pregnancy. It's expected after the birth, and it's treatable in most of the time. Something to also sort of keep an eye on, or like in the back of your mind, is opioids are what we're talking about today. But there are other sort of abstinence or withdrawal syndromes that can occur from other substances that a mother might have been exposed to or using during pregnancy. And anyone who takes care of this population knows that sometimes it can be alcohol or benzodiazepines, other stimulants. A lot of times there's a crossover between tobacco and SSRIs in the withdrawal of a NOWS baby. We'll talk a little bit about that in a minute or two. Something to be really cognizant of, and I mentioned it, but I mention it again because it's important to make the distinction that a newborn's not addicted to anything. They were exposed to it, but they're not actually addicted. And therefore, because they're not addicted, it's a more treatable condition once the withdrawal occurs. And that the interactions that the maternal, the mom and the baby have are really important for the long-term effects of how the success of the baby and even the mom sometimes in her recovery can be. And so just thinking about when we treat these dyads or these families, is just thinking about how this is a disease and it requires compassionate and ethical and really equitable. And the thing that is the hardest is that it requires evidence-based care. And a lot of the people I've worked with really feel the evidence-based care in terms of how we take care of our patients in this specific situation. The diagnosis of our babies who have NOWS or NAS, it doesn't really say that there's harm on purpose happening to the baby, and it shouldn't be used when we're thinking about how to take care of the baby after to punish or to make the family who had this baby who now is experiencing NOWS feel bad about the baby. There's lots of things that go into this disease, and we have to make sure that we're treating it like a disease and helping families get through it in critical time. And I will also caveat that I take care of neonates who are just born in the first, in this situation, the first 72 hours of life. And so mostly a hospital-based approach is what I'm going to also talk about. So like I said, NOWS was formerly known as NAS or neonatal abstinence. We're using NOWS because it's a more accurate description and it will help us sort of reframe how we think about the baby and the mom in this clinical situation when they're born. And then really the big question is, okay, so the baby's not addicted, they've been exposed to opioids, and now they're withdrawing. And so as a clinician or a person taking care of a family or interacting with people in any kind of clinical or like other situation, what is happening to the baby when you see them? And so really what's happening is the baby was receiving opioids, and now we've cut the umbilical cord, and now the exposure creates an abrupt end to the opioid sort of hitting the places where opioid receptors live in the body. Okay, so opioid receptors in the body are in a lot of places that we see some of the clinical symptoms appear. So mostly in the nervous system and in the GI tract. So a baby who's experiencing NOWS, They will have a lot of CNS or central nervous system hyper-irritability. There's a lot of I's and R's in that word, it turns out, when you're trying to read it and talk about it. And so they will have a high-pitched cry, sometimes a decreased sleeping, lots of tremors. The little babies already kind of tremor, but babies who are experiencing NOWS, yeah, I almost said NAS, who are experiencing NOWS will have more excessive tremors that seem out of proportion to what you would expect for a baby. And then in some very extreme cases, or if withdrawal happens in a way that we try to avoid, babies can have seizures. We don't see a lot of seizures in our babies who are withdrawing from opioids, but we do see a lot of tremors and decreased sleep because they tend to wake themselves up with the tremors. We also see dysfunction of their autonomic nervous system, and what that looks like, that's like a lot of things to say. What it really looks like is kind of when babies do extra yawning and extra sneezing. Babies actually sneeze a lot after they're born because they have a lot of amniotic fluid in there, but they sneeze excessively. You're like, something's a little bit different here. And then in the GI tract symptoms, we can see frequent stooling, watery stooling, and then sometimes some emesis, which means vomiting. This is not great for these babies because they are learning how to eat. And so when they're having a lot of stools and eating, it can get us into some other problems, which I'll talk a little bit later too, but not too much in depth. Don't worry, we're not going to talk about poop too much today. And then we talk about some respiratory symptoms. And so these babies will have fast breathing, and then sometimes they'll have a lot of nasal stuffiness. And a lot of these things are really common in all of the babies who are experiencing NOWS and can be really distressing to the families when they see their babies doing these things. Question of sort of when do we start to see these symptoms? The timing actually really depends on the exposure. We're not going to talk about the half-lives of drugs that people are exposed to, but just know that depending on certain types of medications or drug exposures that a mom has can really change the timeline of when a baby will experience some of those things that we just talked about on the previous slide. A lot of our moms who are taking methadone, their babies tend to have some symptoms a little bit later. So 48 to 72 hours will be the onset, and our moms who are taking buprenorphine will happen a little bit like more closer to 48. And then if there were other recreational drug use, sometimes that happens even a little bit faster. And so it's just important when you're looking for timing for withdrawal that you're thinking about what the exposure was to help you guide your management. And there are some studies that show that some of these withdrawal symptoms can like subacutely or like in the background kind of last for up to about 6 months. And then the thing as a clinician taking care of these babies is everybody presents in a slightly different way. And has a lot to do with sort of the body that was exposed to the drugs. So opioids come in lots of different formulations, and so there's immediate release ones, there's sustained release that have a little bit longer time, and then if someone's on a maintenance dose, they process and metabolize and transfer those medications and drugs to the baby at different rates, depending on what their body is doing with those medications, and then that can actually really influence sort of what the withdrawal will look like in the baby. And there's really no way to determine what's going to happen. And so it's really just paying close attention and kind of knowing the background so that you can interpret things clinically with some history. And then I think I talked a little bit before about how cigarettes and SSRIs and benzodiazepines can have their own withdrawal symptoms, but then also sometimes in the setting of an opioid withdrawal, we will see some withdrawal from nicotine or from SSRIs, which are really common for a lot of our moms in treatment to also be on some of these substances. And the timing is really important here because nicotine withdrawal happens very fast, SSRI withdrawal happens very fast, and the treatment of those is a little bit different than the treatment of, I shouldn't say a little bit, the treatment is pretty different than the treatment of opioid withdrawal. And so we don't want to treat nicotine withdrawal the way that we treat opioid withdrawal because we won't actually fix anything. One of the questions that I get actually a lot from a lot of the residents and the students who come through is, this mom is on a lot of methadone. What's that going to look like for the baby? Or this mom is on the highest dose of methadone I've ever seen. Or this mom's not on a lot of methadone. Is that going to mean that the baby's not going to have a lot of withdrawal? Or you can insert any, the buprenorphine too. And the truth is, there's not really been, in studies that have been looked at, not really a relationship between the doses of maternal treatment and the severity of the NOWS clinical symptoms that we see in infants. And so reading those studies and then seeing it in the nursery, it's really clear that it's hard to determine and hard to guess. So we just don't. We just kind of take our cues from what baby's doing. The only thing that is kind of that might be correlated is that a higher dose of opioid exposure, especially with immediate release opioids, can maybe increase some of the symptoms that a baby might have of NOWS. And that's because immediate on, immediate off will cause more symptoms. And so just keeping that in mind. I also think it's kind of interesting. And I think that a lot of the dosing related or the not dosing related NOWS symptoms, I think, has to do with what I talked about before, which is the way that patients and people's bodies metabolize and transfer some of those medications and drugs. So this slide, when I put this slide up there, I freaked out because it's already 2025 and there's some data, but I can't find a good graph that's as good as this, and just really to give, and it still says NAS. And my daughter, who was watching me put this talk together, told me, "Mom, it's not called NAS." And I was like, "I know, but I can't change the graphic." So this should say NOWS because the incidence of NOWS is increasing. I think we had a little dip at some point, but the important thing to take away from this slide is just that NOWS in the United States and in lots of places in the world was not a great like an indication that we saw a lot, and then over the beginning of the 2000s and into present time has increased and stayed high and not dropped back down. And so this is a population that we see pretty frequently and requires a lot of, I think a lot more, like we're doing a lot of research and requires a lot more attention. And so it's exciting when I get to see people and work with people who are giving them that attention. Okay, talked a lot about what NOWS will look like. So now it's what happens after a baby comes out. So I don't know why I wrote delivery day, but I did because it's also birth would have been an appropriate thing to write on there. But once the baby comes out, for me, that's the time that it's time to work together. There's lots of people involved in a birth event at a hospital, and we don't generally wind up sort of meeting each other until there's a mom and a baby. And so this is why I said work together. Things that go into the clinical assessment of a baby, just in general, but especially in a baby who we know or is suspected of experiencing NOWS, would be to get a really great history on the mom, because the baby doesn't really have any history yet, but they will pretty soon after birth. And so mom's history really is baby's history. Getting a great history of mom's medications, both her prescribed and non-prescribed medications, figuring out what kind of social setting she will have on discharge in order to help provide resources and support. Talking about maternal mental health and making sure that we're supporting our moms and families with their mental health concerns and disorders, which we know can have a really big impact on what sort of brought them to this experience to begin with, being opioid exposed. It's important to realize and to note when you're thinking about a baby who has NOWS that they might also have some maternal infections that could be clinically relevant, especially hepatitis C and HIV. Making sure we're getting those histories so that we're appropriately treating and monitoring babies. And then really talking about the things that these families need, because we know they're at risk, to make sure that their social determinants of health are addressed and being supported. Things like food insecurity, and then really things that are needed that weren't needed before, in order to take care of a baby? Do they have a car seat? Is there a bassinet or a laundry basket or somewhere where the baby can sleep? And then figuring out what method of feeding our families are preferring, and then making sure they have access to those, and good education about where they're going to get the supplies that they need in order to do that, or to pump, or to get the formula that they need. It's really important for me to think about a baby when they come in and think, this is a baby. Yes, they have nous, but also they're a baby. And so they are also at risk of other things that all other babies are also at risk for. And so this is sort of the don't worry about the zebra. There's lots of other horses. And so most babies are born and we think about all of them, and we make sure that they don't have sepsis, that they don't have hypoglycemia. Hypocalcemia is a little bit less of a normal baby thing, but that increases tremors. And so that's why it's on this list. And then making sure they don't have neurologic injury, which can lead to seizures and some other tremor-like activity that can be, misdiagnosed as nous. And so making sure that you're thinking about the whole baby and that we're not missing something else in the maternal history or in the baby history that can lead to a false closure on a diagnosis because we're only thinking about nous and the baby's withdrawal syndrome. And then while we're talking about diagnosing and just determining whether or not a baby has nous, I think it's a really important sort of caveat to think about the nuance between screening and testing. I think, at least when I talk about it here in the baby world, I kind of use them interchangeably, but I think that when we're thinking about it more broadly, it's really important to determine the difference between. So there's screening, which most of the times for this population winds up being a validated, usually a verbal questionnaire or instrument that we use to get at sort of the base of risk and problems that a family or a mom might have. ACOG actually recommends all pregnant people are screened at their first trimester visit. There's a couple of ways to do that. There's a lot of validated ways to do that. I wrote 4 Ps here for adults. I know there are more. There's the 4 Ps. There's the 5 Ps, 5 Ps plus. There's the NIDA quick screen, which I was told by someone who's near and dear to my heart that if you ask too many questions, the NIDA quick screen becomes the NIDA long screen. But it's really important to screen for risk assessment so that we can start treatment and evaluation and support as soon as possible. And then there's the 4 Ps, 5 Ps, those are all validated for adults. And then there's different ones for teens just based on what their social situation and group looks like. And then to think about what testing looks like, testing, if we're saying it in the setting of drug testing, really is a diagnostic test. And for our moms, that's really urine and blood. It's really important to make sure that we're talking to our patients about drug testing, because depending on where you're doing this drug testing, it can lead to other things, which I will talk about in a minute. But really, it's making sure you're consenting to doing the testing, or at least telling them that once we do this, there are some outcomes that we might use to treat the baby, or that we need to refer you for services because we know the baby's at risk, because it becomes much more complicated once there's a baby involved. So the testing that we do in the hospital, or the ideal state, is that our moms downstairs get a urine toxicology screen. See, I said it, urine toxicology test for substances. Then we can use that to sort of inform how we are taking care of baby, or how we're evaluating, monitoring, and taking care of baby. Sometimes it happens and sometimes it doesn't. And then once the baby's born, if we don't have that information, or if we need more information from the maternal toxicology screen, we do screening on babies. And by screening, I mean testing. And so the way that we do that here, and in a lot of places, we do a combination of urine toxicology and meconium toxicology screening. Urine toxicology comes back very fast. Most places will run it in-house, but doesn't always test for everything. And really the timing for a urine toxicology is just a couple of days. So if a baby is born and you do a urine toxicology on the baby, you can know what substances they were exposed to maybe 48, maybe 72 hours before delivery. Meconium gives you a little bit of more longitudinal data. And if you do a meconium test, you can have 30 days worth of information in terms of, sometimes more, information about what the baby had been exposed to in utero. And then using those two things together with maternal history, maternal toxicology to start making your clinical decisions and taking care of the dyad. I wrote umbilical cord testing in here because a lot of places love umbilical cord testing because it tests for tons of things, way more than you can test for with meconium and urine. Umbilical cord testing has some ups and downs. The ups are the ones that I just said. Some of the downs are storing an umbilical cord, and then sometimes the umbilical cord, some studies would say that it's not quite as good or as accurate as some of the other testing that can be done. And then the other thing that I wanted to make sure that I mentioned was what I was sort of alluding to on the other slide, which was maternal urine toxicology screening, and just making sure that we're consenting our patients when we're tox screening them, because some states and some places, if you have a positive drug test with or without a pregnancy, there can be mandatory reporting of the results of that test to law enforcement. That is not what happens here in North Carolina. So I don't have, honestly, a lot of experience with that, but it's important to note that that might be present in your location. So then I think it's important also when we're talking about sort of evaluating and I'm going to say labeling, but really putting a problem on a problem list. It's important to think about the implications of what that like why we do it, why it's important to recognize it, and then what are some of the long-term sort of implications of having that disease and putting it in the problem list for a patient. So I alluded to this a little bit before. When a baby who has NOWS is eating, sometimes they do a lot of stooling and they do a lot of vomiting, and that is unfortunate because they also have a relatively high metabolic rate because of the withdrawal. And then they're also having usually will have some poor feeding because of some of the neurodevelopmental delay that can happen as a result of opioid exposure in utero. And then what that looks like here on the nursery floor is it can look like really poor feeding. And then that leads to something that pediatricians really go a little bit crazy about, and that is weight gain and weight loss. And so our babies who have NOWS, who have poor feeding, an increased metabolic rate, who are doing a lot of stooling, they have a lot of weight loss. And we expect babies to lose 10 to 12, depending on who you talk to. They might tolerate more % of their birth weight. But it's really difficult to get them feeding well and to give them enough calories in order to get them to eat. And that can be really distressing for our parents. And then also once they are in the outpatient setting, it can be really difficult to get them back and reassess and get them the right amount of nutrients that we know they need for brain growth and weight gain. After birth, and then after discharge, they tend to have some continued neuroirritability. And this is hard for our parents who are already stressed. Babies, taking them home is real fun. And then also it's really stressful. And so I think that the increased neuroirritability makes that already stressful situation and a patient and family who are already at risk, it makes it even more stressful. And then there's the question of once they get a little older, are they having withdrawal or are they having colic or are they having both? And so just sort of recognizing when you're encountering these people and these patients and the babies that there's a lot going on. And then they're not eating too. I forgot to mention that. So if they're not eating well, then they're also not satisfied and still crying. There's a lot going on and it can be really hard. And then also just to think about things like involvement of so like services that can be helpful, but that can also be viewed as punitive to the families. And so CPS involvement is really great. We actually do a lot of referring to CPS so that they can provide early services and support. But that does have a lot of sort of stigma and social implications for families and for the newborn sort of encounter and the way that that feels for the family. So those are sort of the shorter term things that we deal with and think about, but there's also a lot of longer term implications, and that's the part that's been really difficult to study. And there have been some studies about long-term complications. It's a difficult population to study. There's a lot of different influences and factors that go into sort of what we're trying to study. There was a study in 2012 called the Mother Study. It was a really large randomized control trial, that found no significant difference in some of the neurodevelopmental outcomes or growth outcomes between the infants that they studied that were on buprenorphine and methadone. But other studies, that have come after and before have found sort of some variable results in terms of the things here, like neurodevelopmental delays, learning disabilities, growth problems, and behavioral issues. This is just a little overview of the Mother Study and the outcomes. They studied babies 0 to 36 months. They had 96 children, which is a lot. And like I said, there was no pattern of differences in the physical or behavioral development to support buprenorphine over methadone. And there was also no, so our infants who had NAS, or what I've been calling NOWS this whole time, ones who were treated versus ones who were not treated, there was not a difference for them either. And then also when they looked at it, there wasn't a pattern of difference when they compared them to test norms. And so really it's the result of that trial was really indicating that children born in this study, they followed a path of pretty normal development in terms of their growth, their cognitive development, and their psychological development. And then just obviously, because this is what we do more studies. Other studies have come that have shown some differences, some without differences, some that showed, tobacco. If we added tobacco, that also caused some more changes and cognitive issues. And so it's just important to note that just like the presentation is variable, we can't always also determine what the baby will look like in 3 years. But it seems like if we do it right in the beginning, we were doing a good job and we were setting people up for success. Okay, so now I'll talk a little bit about the management of NOWS and what we do kind of in the hospital. We know hospitals are a terrible, terrible place to rest, to get better, even though that's where we send everybody when it's time. We know that there are some things about hospitals and hospital policies that can be good for NOWS and some things that can be bad for NOWS. Things that we know that in a hospital can reduce the severity of NOWS is the presence of a protocol of how we're monitoring, taking care of, and treating these babies. We know that breastfeeding can reduce the severity, and we know that keeping mom and baby together can decrease some of the severity of NOWS. We know that a very large thing that increases NOWS is being in the NICU setting, which is where we used to, and then sometimes in some other places still have to send our babies with NOWS to the NICU setting for the correct amount of monitoring and treatment. And then things that we know can reduce or increase or change the severity of NOWS is the choice that we use to assess and treat our babies, the medications that we use in order to treat our babies, and then sort of what the initiation, weaning, as needed protocols for medication treatment look like. Excuse me. So the AAP, and I use the AAP a lot because that's where we are, sort of guided by at UNC. And other resources like the WHO does not have specific NOWS guidelines, but they do have broader guidelines for care of infants, and that does include care for NAS and NOWS, and it looks a lot like what the AAP recommends. Really, what they recommend for identifying and taking care of a baby is to identify the risks and appropriately monitor for withdrawal based on the exposure type that a baby might have. And then they also recommend that every nursery should have a protocol, but not only a protocol, a written protocol, so that anyone who is sort of rounding or talking to or covering a team can look at the same protocol and use a standard of care for this group of patients. And then they recommend that you use a standardized tool for evaluation and management. We'll talk about this. And then prioritize keeping mothers and babies in the same room throughout the hospital stay. And also that they recommend that mothers on treatment should be encouraged to breastfeed. As we said before, we know that that can decrease some of the severity of the withdrawal. So in general, sometimes it's clear as mud whether or not we can determine if, even though we went through and did maternal history and did maybe some drug screening or testing, it can be difficult to determine which babies will have NOWS. And so if there's no maternal history, if there's positive screenings, if there's drug testing on mom and baby that are positive, those are pretty definitive. Otherwise, it's a little difficult. So just like the AAP recommends, our hospital has made a recommendation. This is all based on lots and lots of like NOWS and NAS studies. And this sort of guides our management of when we recommend toxicology testing for moms and babies. And it really helps take some of the guesswork out of it. And this is really meant in our hospital, and I think in a lot of hospitals that have this kind of guidance, it's really meant to sort of guide your testing to make sure that you are doing your testing based on clinical presentations and known risk factors so that we can decrease some of the stigma and bias that we are attributing to certain diseases just based on what people look like when they come into the hospital. And so I think this is all pretty self-explanatory. I am going to read them though, because I think they're kind of important. And the first one is the one I get the most questions about from my residents. It says absent, inadequate, or late prenatal care, which is great. But we made sure that we defined this very clearly based on a lot of research that was done to what this actually means and what the risk is transferred from the absent, inadequate, and late prenatal care. And so we define it here as fewer than 4 antenatal visits or the first visit in the 3rd trimester. Obviously, I said before, a known substance use disorder is an indication for testing. A new diagnosis of hepatitis C, B, HIV, or syphilis during pregnancy, just knowing sort of what risk factors put you at risk for getting those diseases make it more likely that we should test you. Mothers who are exhibiting symptoms of active substance use, placental abruption with no other cause, and then newborns who are exhibiting signs and symptoms that are concerning for withdrawal, which is why it's important to note the other substances that we talked about before and others that I didn't mention that can also cause some clinical symptoms that look or could mimic opioid withdrawal. So I've said a lot of things. Now we're in the hospital, the baby's born. There's a lot of maternal history we've had to get. We've talked a lot about screening, toxicology testing, both on the mom and the baby. And now there's even more things that we have to think about. And that's, should we recommend breastfeeding? Should we not recommend breastfeeding? Should we take care of, how should we monitor the baby? Do we use Eat, Sleep, and Console? Do we use the Finnegan score? Do we have in our hospital or in our location a way to monitor our babies if we're worried if they're withdrawing? Do they require child welfare involvement? Do we refer them for a plan of safe care? These are all things that come up that some people might have different answers to. And so in our protocol, which I love sharing with people, and if anyone's interested in seeing this more in depth, I'm happy to share it. We sort of put all of these things over the top, and then all of the substances that we commonly see down the left, and then give guidance so that our providers and nursing staff and lactation consultants and everybody who can have access to this, and we can all be on the same page. Does that always happen? No, we also have to talk, and I'll talk about that too. So I do highlight a couple of things here that I just want to draw attention to. So breastfeeding tends to be a pretty hot topic, and when we're talking about breastfeeding, this says encourage, which when I actually say it out loud is a funny thing to say. We counsel and we make sure that our families know the risks of breastfeeding with exposure to the substances that they're using. And so in the place of cannabinoids, we encourage in the same way that we encourage a mom who drinks wine sometimes. We say, this is really not a great idea. Definitely don't drink wine and then feed your baby. There's risks with that, and we don't really know all the outcomes. And so we teach. It really should say teach and support instead of encourage. Same thing for our dyads who come in where the mom's on prescribed opioids. We talk about you know, let's teach you the risks. It's a great thing to help with some of the withdrawal. We know that you're in a good spot with your medications and your treatment, and let's make sure that we give you the best opportunity to breastfeed and to bond and to make this look the way that you need it, that you want it to look in your postpartum period. There are unfortunately a couple places where we actually strongly discourage breastfeeding, and that's in the case of where there's like a cannabis use disorder. And then if they are enrolled in an active treatment, one of our Health and Human Services and the new breastfeeding medicine guidelines sort of say you should encourage everyone and teach them and let them enroll. And so that what we do is we discourage them from using cannabis and breastfeeding, but we encourage them to learn how to breastfeed and get what they need in order to do it safely. If we have a mom come in who has non-prescribed opioids or cocaine or polysubstances, then we actually do discourage breastfeeding because of the risks to the baby. And then we try to counsel about what those risks are, what they look like, and then support if they do want to learn how to breastfeed, support them in that, and then discourage them from using the milk during the time where those substances are present, especially in the hospital. Okay, so the other thing that we do is we use Eat, Sleep, and Console as our tool to evaluate and manage our babies. And so the question I get a lot is, when do we do that? Do we do that for, like, if a mom's not using marijuana, or do we do that if there's cocaine? And the answer is we do it for opioids. And so I circled these. I know it's obvious, but I circled them because we really did have to put this on here to make sure that we're doing the right thing for the patients who come in. I think it can get confusing, and that's why this is a great tool. If we have a substance like cocaine that we find in someone's urine, no, they don't need to be observed for 72 hours for withdrawal. Do we think it's great? Do we do a lot of other things? Yes, but we do not need to do Eat, Sleep, and Console. And then this is something that we've just recently added, really just to decrease some of the burden of healthcare on families who are already sort of like in it and trying really hard and doing their best. And if we have, like I said, the Horizons program close by, they're getting urine drug screening, they're in treatment. If the mom gets a urine drug screen here and it looks the way we expect it to based on her meds and based on her treatment, we try to respect the amount of work that she's been putting in and not also screen the baby. The reason is that when you do the urine and the meconium drug screening, there's a lot of stuff in the diaper and it's a little bit confusing. And then when people see it, they ask a lot of questions. And so if we can avoid adding more stress, than we do, but only in the case where we feel like it's safe for the babies. The only caveat to this is, I think this row over here that talks about child welfare, it's really important, I think, when you're talking about child welfare, to note that I've got good access to it, but not everybody has great access to it. And just making sure that ours says, we will do this, this is the support we will initiate. That's not going to look the same everywhere. It's really just supposed to look the way that it needs to look in whatever area you're working. And that's really the goal of the CPS involvement, is really for support and monitoring and making sure that we're setting our dyads up who we know are at risk with initial support. Not everybody accepts it, and that's okay, but we make sure we offer it. Okay, so we'll talk a little bit now about standardized assessment tools. Better hurry up. I usually talk faster than this. So once we determine that a baby has NOWS, they are minimum in our hospital for 72 hours, sometimes longer, but the minimum is 72. This is amazing because the length of stay used to be 21 days, 28 days, longer. And so It seems like a long time when you've had a baby and you want to get the heck out of the hospital, but 72 hours minimum for evaluation. And then what everyone gets here and in other places here is a scoring tool. And so there are a couple of them. I'm only going to briefly talk about the modified Finnegan scoring, which is, I think, the most common one that's currently still used everywhere. And it was created in the 1970s. And things that people who like Eat, Sleep, and Console don't like about the Finnegan scoring is that it can be disruptive to bonding and to the infant. And Eat, Sleep, Console is another method which we're going to talk a lot about, so I'm going to quickly go right through it. This thing on the right, don't read it. It's a lot of noise, but that's a Finnegan score. There's lots of little things to look at. A baby gets, a score for each one. We add them up. If they go above a certain number, we think, if this happens and we again and again, then if we get a score of greater than 24, maybe after a couple of times, or higher than a certain score during a certain time, then we should probably start treatment. This is hard because in order to do this Finnegan scoring, you have to wake up a baby. You have to sort of, even if they're sleeping, and then they get irritated and they're already hyper irritable and hard to fall asleep. And so some people don't love Finnegan scoring. It works really well. It's been working very well for a long time. And we know that when we use a Finnegan score to score a baby, it does a good job of keeping a baby safe and identifying their withdrawal symptoms. So that's great. There's no evidence anywhere that actually says that Eat, Sleep, and Console is better than Finnegan, although I do think a lot of people who love Eat, Sleep, and Console have other reasons that they like to use it. The only point that I'm trying to make is that it's the clear point is that using Finnegan scoring, if you're going to go with that, that's what you should do. And everybody who's scoring a baby should learn how to use it. And so that you do the same thing every time. If you're going to do Eat, Sleep, and Console, everyone should learn Eat, Sleep, and Console and score the baby that way so that they do it the same every time. And that consistent approach to scoring really helps with outcomes and with identification of these babies. So I said Eat, Sleep, and Console a lot. I feel like I say it a lot just in my very daily life. And so I thought I should take a minute just to say why Eat, Sleep, and Console came about. There's a couple of studies. I'm going to blow through the studies. Really, we know that separation of a dyad in early life, really with any baby, can lead to poor attachment and bonding, decreased breastfeeding rates, and then disturbed infants emotionally and cognitively. Right. And we also know that dyads who are impacted with maternal drug use are at increased risk of all that stuff at baseline. And then also, if they're also at increased risk of other things that are a little bit scarier, like non-accidental trauma, readmission for probably some of those things we talked about earlier, which causes more stress, and then loss of parental rights, formula feeding versus breastfeeding. And so people thought, what if we could sort of keep the babies together and do sort of the natural, like normal baby transition into postnatal life, and also, sort of use a normal baby stuff to help ease withdrawal. And so, really, what can we do to help give our caregivers a bigger hand in helping with taking care of these babies who are experiencing NOWS? And so Dr. Grossman and his friends up at Yale, they were like, this is a good idea. So what they did was they did a long-term quality improvement intervention where they took babies who were methadone exposed, and they treated them like they would a baby who was fussy. And so they kept them with their mom. They did skin to skin. They increased their formula. They did, sort of floor management and kept the moms and babies together, did more non-pharmacologic care, like shushing and keeping it quiet. And they were like, let's see if this works as a way to assess for NOWS. And turns out that it kind of worked. And really what it turned into is the way that the assessment tool that they came up with works is, does a baby eat like a normal baby? 1 ounce might be a little generous for a first day, second day baby. But if they eat a normal amount for a baby, are they sleeping pretty well undisturbed between feedings. And if they're really, really angry, are they consoling within 10 minutes with normal methods like bouncing and shushing, side lying, all those kinds of things. And while they were doing this, they continued to do their Finnegan scoring in the background to make sure that they weren't missing anything that we know the Finnegan scoring can identify. And so what they basically found is the length of stay. Length of stay is less important to me than the fact that families get to go home sooner and have better access to their meds and their treatment and their support groups at home and not being stuck in the hospital for 22 days. They dropped their length of stay. The cost to the hospital was less. Hospitals love that. And I think, which was kind of amazing, is that the morphine treatment, or the treatment that was necessary to give more opioids to a baby who already had opioids, because I will tell you that giving a baby who can't eat super well because they're disorganized, giving the morphine does not make them eat better. And so it doesn't make the situation a lot better. They give way less morphine or opioid sort of pharmacologic intervention after that. And so really the emphasis on this whole study was really on the clinical picture of the baby, trying to do non-pharmacologic management, and then doing a little bit like less disturbing, less monitoring, more like, dyadic care at that time. And so there are a lot of people who did not like it because it was not proven. So since Matt Grossman in 2017 did that, there's been a lot of places that have done Eat, Sleep, and Console and some studies on it. And really what they found is that Eat, Sleep, and Console makes a family, a dyad, a baby ready for discharge sooner because we keep our moms in there, our dads in there, and they learn how to take care of their fussy baby. The baby does great. And then we worry less about the withdrawal because we know how to take care of it. And then the safety is actually the same as the usual care that we were giving before. And so it's pretty interesting. And I think since then, and since a lot of these more studies have come out, it's been a lot more adopted, and people have been a lot more open to it. And I think it works really well. This is very brief, as brief as I can be. If we are not eating and sleeping and consoling, that's step one. We go to step two. In step two, we maximize some of the non-pharmacologic stuff. We lower the lights, we turn off the TV, we do skin to skin, we do lots of breastfeeding if our moms are interested in it, and then we see how it goes. If a baby does not respond well to that, then we step up our treatment. We hold it as an interdisciplinary meeting, we assess the baby, we talk to the family, and then we decide, do we want to try more pharmacologic or non-pharmacologic treatment, or do we think we're at this point where we really need to initiate pharmacologic treatment? I'm going to skip over this and this. I think it's important to note that really the non-pharmacologic stuff that we do is great. And then the pharmacologic stuff is also okay. We don't want our babies who are having withdrawal symptoms to suffer. Nobody wants them to suffer if they're not feeling well. They can't tell us, and so really we have to pay attention to what they're sort of saying. I think it's great when they're in the room with their parents, because even though they're new, and I tell them this, that even though they're new, you know them the best, and so if they're acting different and you feel like they're suffering, that's really great information. And then it's really important to note that pharmacotherapy is not failure. Like, the goal of Eat, Sleep, and Console is not to avoid giving babies meds. Like, if they need them, they should be getting them. Really for us, it's about making sure that they need them before we give them, because some of the other things like tobacco and SSRIs, they can really interfere. And it's important to note that the baby is not doing well in the situation that they're in based on the clinical picture that they have. And is that opioids? And if it is, then we should treat it if they need that. The interesting thing that we've done a lot is done as needed, or PRN dosing of opioid treatment. And that has really been helpful, because we found there's a lot of babies who have about a 6-hour period if they do need treatment, where they get treatment times one, and then after that they actually do pretty well, as opposed to starting treatment on a scheduled dosing basis, and then you wind up being stuck having to wean it and get rid of it when the baby would have been fine without it. That's not always the case, but it can happen. I think the important thing to remember here is just to pay attention to the clinical situation, the picture, and the patient, which in this case is a baby. The only other non-pharmacologic intervention that I really want to talk about, or is breastfeeding. It's by far the most studied non-pharmacologic intervention. It's been found to be safe for mothers who are on methadone and buprenorphine to breastfeed. We know it can reduce the signs and symptoms of NOWS, and it can decrease a hospital stay. And so whenever possible, if a family is really interested in breastfeeding, we make sure that we support that. Obviously, we talk about risks versus benefits, but we support it and allow our moms to have the experience that they want, or like provide them with that if that's what they want. We know it's good for moms to breastfeed. It helps with recovery. It helps with bonding, and we love it. And then I put this slide up here just because I felt like we hadn't seen it in a little while, and just to again sort of highlight that we really encourage it in the setting, breastfeeding in the setting of prescribed opiates. I should have made the opiates one green and not the cannabis one. So the last kind of thing that I want to talk about Eat, Sleep, and Soul, I would love it in our nursery, is that it really emphasizes the family as medicine for the baby, and decreases a lot of guilt for especially the mother, but I think the whole family when they're able to help with the care and evaluation of their baby. And we've had really great success. I will say that when we first started in our nursery, our team was really nervous because we had been doing Finnegan scoring, and Finnegan scoring has a number, and when the number is something, then we treat, and that's nice for everyone. This leaves a little bit more of a of like an evaluation and a team-based approach, but I think it also leaves more space for the families to feel part of it, which is really, I think, helps to set this particular group of patients up for success once they go home. I'm going to skip a couple of these slides. I cannot believe myself. The other thing is, which I just really want to make sure I mentioned, is Eat, Sleep, and Console for me really helps get the dads involved. And because they can do the skin to skin, they can do the rocking, they can do that. And it's great for moms, babies, and dads to all sort of be part of that, birth event and bonding. So very, very briefly, I'm almost done, I promise. I just want to talk about team-based care. So success in general depends on the entire team in the hospital. That team is enormous when you're in the hospital. And I will show you this graphic that I made with one of my quality improvement projects about how many people come into the room of a mom and a baby when they're in the hospital. If you look, this is over a 2-day period, and there are, I don't know, 25 different encounters with different team members. And if you think about all those different team members who are taking care of this dyad, what that can really lead to is frustration and confusion on the part of the family, decreased trust in the medical team if we're all coming in and saying different things, and then really frustration between the teams if the teams are saying different things. And so we've trialed a couple of things to try to get our team members all on board. The team members that we try to get on board, this is just like kind of a small list, our OB, peds, sometimes family medicine, lactation, nursing, our CSTs, our phlebotomists, try to get them all on the same team so that we can talk about how we're going to approach the care together, which is hard. It's hard to get these teams to talk to each other. We've tried things like a labor huddle. We've tried an Eat, Sleep, and Console, or like an opioid exposure consult pager. And then we've trialed it on multiple patients, and it really works well to get all these people on board first. So the algorithm I showed you with that table is our PEDS algorithm. So then what we wind up doing is sharing that, talking about it, making a plan with OB, PEDS, and lactation. Those are kind of the main ones that we wind up having to have the biggest discussion with. And of course, nursing. I don't think we could do this without nursing. And really, because I cannot believe it's 12:59, I found this graphic and I love it because really I talked a lot about the neonatal period and kind of like that just before birth, and right after, but the opioid epidemic and exposure to opioids for especially our pregnant moms is a clinical presentation that really we need to be working on from the beginning to the end, and then even after the NOWS is gone, or the immediate period of NOWS is over. And so I just think that this is beautiful, and a beautiful way to sort of mesh how everyone is how the sort of progression from pregnancy to sassy toddler. If anyone has questions, please let me know. Thank you so much for letting me come and talk. I really feel very passionately about this topic and how we care for and make these patients feel supported and respected when they're here to deliver.
Well,
Dr. Sweeney, I want to thank you on behalf of the Global Women's Network for taking your time today to present this incredible information. And we did get a question in the chat, which was, will these slides be available for
I believe so.
distribution?
I can send them.
That would be wonderful.
we'll also send a link to the recording. We'll do the PDF version of the slides. So we'll send that to all the attendees and the registrants today, so we can do that as well. Thank you so much, Dr. Sweeney. Wow, you just provided so much information. You're like a wealth of knowledge. You're a great presenter. We've all had all positive comments in the chat box. I don't see any other question except for what just Senga just talked about regarding the presentation slide. So with it being one and no questions, we can go ahead and close out this session today. And just
Awesome.
thank you, everybody, for being here. Thank you, Dr. Sweeney. Thank you, Senga. On behalf of the Global Women's Network, Drug Free America Foundation, thank you so much for sharing your wealth of knowledge today.
Thanks for having me.
Thank you, everyone.